Today we're going to explore one of the most common and misunderstood orthodontic findings, buccal eruption of upper canines and the broader problem of dental crowding. This is not just about alignment or aesthetics. It's a window into how growth, timing, and space management interact in the developing mouth. We'll walk through 3 real cases from clinical practice, each of them teaching us something unique about diagnosis, planning, and long-term stability. Let's begin. Crowding occurs when there simply isn't enough space in the dental arch for all the teeth to align properly, and among the teeth most often affected, the upper canines stand out. Why? Because the canine is the last anterior tooth to erupt, it often finds itself with little or no room to emerge into its ideal position. When space is lost early in development, or if eruption paths are disrupted, the canine seeks the easiest route, often erupting buccally or outward toward the cheek. This displacement is not random. It's the mouth's adaptive response to spatial conflict. And that's exactly what we see in our first case. Case 1. An 11-year-old girl with a simple complaint that carries deep clinical significance. She says she doesn't like how her fangs look, and her classmates have started teasing her, calling her fangs. This single word already tells you something about the psychological impact of early dental irregularities. It also tells you how visible the canines are when they erupt buccally. A girl's mother mentions that her baby teeth were also a bit crooked, and both are now eager for orthodontic treatment. Medical and dental history. A girl has mild, well-controlled asthma. She uses a salbutamol inhaler, but is otherwise healthy. This detail matters clinically. In asthmatic patients, inhalers, especially beta agonists, can dry the oral mucosa and alter salivary flow. That increases the risk of plaque accumulation and gingival inflammation. It doesn't prevent orthodontic treatment, but it means we must be vigilant about oral hygiene and appliance care. Examination. External findings. A girl's facial profile reveals a Class 1 skeletal pattern with an average Frankfurt mandibular plane angle. Her lips are competent, her chin point slightly deviated to the right. Nothing alarming, just mild asymmetry, which, remember, is normal in most faces. Her mother hadn't even noticed it, which is often the case when asymmetry develops gradually. There are no temporomandibular joint symptoms, no functional deviation. So we can focus our attention on the dentition itself. Intraoral findings. Intraorally, several important observations emerge. There's generalized marginal gingival redness, an early sign of plaque irritation. Plaque deposits are visible on the upper canines, particularly both 3s. A girl is in the late mixed dentition stage. The lower front teeth show moderate crowding. The upper central incisors are slightly rotated mesiolabially, and both permanent canines, the upper 3s, are erupting buccally. The molar relationship is asymmetrical, Class 1 on the left, but Class 3 on the right. The lower central line shifts slightly to the right. Her overbite is complete but average, a healthy depth. This gives us our first diagnostic framework, a Class 1 malocclusion on a Class 1 skeletal base with moderate upper and lower crowding, and buccally erupting upper canines. Understanding buccal eruption. The core mechanism. Why do these canines erupt buccally? Think of the dental arch like a crowded train platform. Every tooth has a train that arrives on schedule, but the canine's train is always last. If earlier trains, the incisors and premolars, have already taken too much space, the canine has nowhere left to park. So, it pulls up on the outer track, the buccal side, simply because that's where there's room. Crowding, therefore, isn't the result of bad luck. It's the physical consequence of a mismatch between tooth size and arch length. This phenomenon also explains why buccal displacement of canines almost never happens in wide, uncrowded arches. Investigations and diagnosis. A panoramic radiograph confirms the presence of all permanent teeth, including the developing third molars. Bone levels are normal, there's no pathology. The diagnosis is straightforward but detailed. Class 1 malocclusion, Class 1 skeletal base, average FMPA, slight chin deviation to the right, moderate crowding in both arches, buccal eruption of upper canines, mild gingivitis, centerline deviation to the right. Under the Index of Orthodontic Treatment, need IOTN, this scores grade 4D because displacements exceed 4 mm, clearly justifying orthodontic correction. Treatment planning begins. At this stage, treatment planning requires two kinds of thinking. First, clinical mechanics, how to make space and move teeth. Second, behavioral readiness, ensuring a girl's oral hygiene is adequate before appliances are placed. Before any brackets are bonded, she should receive multiple sessions with the hygienist. Inflammation must be reduced, and brushing techniques reinforced. Only then should impressions and wax registrations be taken for study models. These models, along with the panoramic radiograph, form the foundation of the referral to the orthodontist. Key clinical thought: always start with the lower arch. A golden rule in orthodontic treatment planning is simple yet profound. Always plan from the lower arch first. Why? Because the lower anterior segment exists in a delicate balance between the lips and the tongue. Expanding it forward or outward risks long-term instability. So we treat the lower arch as the anchor of occlusion, and we let the upper arch adapt to it, not the other way around. In a girl's case, moderate lower crowding means something must give. Space must be created. Creating space. The options. There are several ways to create space in orthodontics. 1. Extraction, the most direct and stable. 2. Arch expansion, increasing the perimeter but often unstable in the lower jaw. 3. Distal movement of molars, effective but limited without extractions. 4. Enamel stripping, removing a tiny amount of enamel, usually in adults, to gain up to 2 millimeters. For a girl, only extractions make biomechanical and long-term sense. Why first premolars? Extraction of the first premolars is the standard approach in moderate crowding. These teeth sit roughly in the middle of each arch, providing space that can be shared between anterior and posterior segments. When canines are mesially angulated, removing the first premolars allows them to upright naturally as they erupt, often aligning themselves spontaneously. It's nature doing half the orthodontist's job. Any residual space then closes as the buccal segments drift mesially. That's why, in a girl's case, extracting all 4 first premolars is both logical and efficient. Fixed appliance therapy and anchorage, after extraction, alignment and leveling begin with fixed appliances. But not all movements are equal. Some require reinforcement. That's where anchorage control comes in. In a girl's case, most of the extraction space will be used for anterior alignment and canine retraction. Anchorage can be reinforced using a palatal arch or temporary anchorage devices, also known as TADs. A palatal arch connects the upper first molars across the palate, resisting forward drift. TADs are miniature titanium screws placed in bone to act as stationary anchors, a modern and reliable method. The guiding rule: plan anchorage before you move a single tooth. Step-by-step visualization of treatment planning. Imagine the process like a chessboard. First, the lower arch. We assess, we plan extractions, we predict spontaneous alignment. Next, the upper arch. We visualize how the canines will move into the space of the extracted premolars. Then, we align the upper incisors and correct rotations. Finally, we aim for a bilateral class 1 molar relationship. The sequence is logical and layered. Each step supports the next, like scaffolding on a building under construction. Oral hygiene considerations throughout treatment. Oral hygiene remains critical. Fixed appliances trap food and plaque, especially around brackets and gingival margins. A girl's mild gingivitis at baseline tells us she's prone to plaque retention. So, consistent reinforcement by both orthodontist and hygienist is essential. Patients must understand that even the best mechanical correction can be compromised by biological neglect. Treatment outcomes and common complications. When treatment is executed well, alignment improves dramatically. But there's a risk we must always mention: white spot lesions. These chalky patches of demineralization appear on enamel after orthodontic treatment. They result from prolonged plaque accumulation and acid attack around brackets. Studies report a prevalence between 2 and 96%. Most commonly, they affect upper lateral incisors and lower canines, the same areas hardest to clean. Preventing them is a shared responsibility. Prevention of white spot lesions: begin with patient selection, good hygiene habits before treatment. Advise patients to avoid sugary snacks and carbonated drinks between meals. Recommend brushing with fluoride toothpaste after every meal. Encourage daily use of a W5% sodium fluoride rinse. Apply fluoride varnish around brackets every 6 weeks. There's strong evidence this reduces lesion formation. In essence, prevention starts before the first bracket is bonded and continues until the last retainer is delivered. Management of white spot lesions. If lesions appear post-treatment, most will fade over time as hygiene improves. Avoid aggressive high fluoride varnish right away. It can hypermineralize the surface and lock the white appearance in place. Instead, let natural remineralization occur first. For persistent cases, use microabrasion with acid pumice slurry. In severe aesthetic cases, composite veneers may be considered. These decisions depend on the patient's age, enamel thickness, and cosmetic expectations. Case 1. Summary. So, what have we learned from a girl? Her case illustrates classic buccal canine eruption due to arch crowding. It reinforces the sequence of clinical reasoning: history, then examination, then diagnosis, then space creation, then anchorage, then retention. And perhaps most importantly, it reminds us that orthodontic treatment isn't only mechanical, it's behavioral and educational. The clinician's role is to coordinate biology, mechanics, and motivation. That's the art and science of orthodontics. Transition from crowding to broader principles. Before we move to the next case, let's pause and step back. A girl's case highlights a fundamental truth about crowding: that the jaws don't fail, they simply have limits. Our job as clinicians isn't to fight those limits blindly, but to respect them and plan within their biological boundaries. Crowding, buccal eruption, anchorage retention. Each is just a reflection of how structure and function must stay in harmony. Deep teaching section. The biomechanics of crowding and buccal eruption. Let's unpack the biomechanics behind these movements in plain terms. When the arch perimeter is shorter than the sum of tooth widths, eruption follows the path of least resistance. If the lip and cheek pressure exceed tongue pressure, teeth tend to drift inward. If the tongue dominates, as in mouth breathers, we may see flaring outward. Now, the canine sits at the junction between anterior and posterior segments. It's the cornerstone of the arch, both aesthetically and functionally. When it erupts buccally, that harmony is disrupted. The arch appears broken, the smile asymmetric. Clinically, buccal canines signal either premature loss of deciduous teeth, delayed eruption sequence, or genuine tooth size arch length discrepancy. Understanding which applies dictates treatment. Cephalometric thinking. Without the math. Even in general practice, you can interpret cephalometric principles simply. A Class 1 skeletal base means the jaws are in harmony front to back. A Class 2 means the mandible sits back. A Class 3 means it's forward. A girl's Class 1 base tells us crowding is dental, not skeletal. That distinction determines whether you extract or attempt growth modification. If the bones are balanced but the teeth are fighting for space, the answer lies in redistribution, not skeletal correction. Retention strategy for a girl. Once alignment is achieved, retention begins immediately. A bonded retainer from canine to canine on the lower arch preserves the corrected anterior alignment. Additionally, both upper and lower vacuum-formed retainers are worn nightly for the first 12 months, then gradually reduced to alternate nights for another year. This gradual reduction allows the periodontium and soft tissues to adapt to the new equilibrium. Retention isn't an afterthought, it's the final phase of active treatment. Case 2. Our next case introduces a different type of challenge. Not mechanical but biological. A 12-year-old girl presenting with crowding of the upper teeth and a possible nickel allergy. Her mother mentions that a girl reacts to some metal jewelry. Before jumping into treatment, this single comment requires investigation. Nickel allergy is far from rare, especially in females. Studies show it affects 10 to 30% of girls, compared with roughly 2% of boys. The difference often comes from exposure through earrings or fashion accessories. Clinical consideration: why it matters. Orthodontic appliances commonly contain nickel in stainless steel brackets, arch wires, and even ligatures. In sensitive patients, exposure may trigger itching, redness, or swelling of oral mucosa. So, the right step is simple but crucial. Refer to a dermatologist for patch testing before starting treatment. Only after confirmation should orthodontic planning proceed. If the allergy is verified, use nickel-free alternatives, such as titanium molybdenum alloy, TMA wires, and brackets specifically manufactured for allergy-safe use. This precaution protects both the patient's comfort and your legal liability as a clinician. Key lesson from this case reminds us that orthodontics is never just about moving teeth. Every patient brings their own biological story. A small detail in medical history, a jewelry rash, a skin reaction, can entirely change your material selection and workflow. For a girl, once nickel sensitivity was ruled out, treatment continued safely using standard components. But her case remains a classic example of biologic personalization in orthodontics. Case 3, now our third case, a girl, age 13. Her presentation is a bit more complex. A combination of crowding, buccally erupting canines, and a mild class 3 skeletal base. At first glance, the challenge looks purely dental, but radiographic and cephalometric analysis revealed deeper implications. Initial clinical findings. A girl's dentition shows mild lower crowding and severe upper crowding. Both upper canines, right and left, are erupting buccally, with the cusp tips barely visible through the gingiva. Her lower incisors appear slightly retroclined, and her upper incisors upright or even a bit retroclined too. She also presents a mild class 3 incisor relationship, with minimal overbite and even a slight anterior crossbite. The upper dental centerline is shifted about 3 mm to the left. The molar relationships differ on each side, class 2 on the right, class 3 on the left. This asymmetry tells us that both skeletal and dental components are in play. Diagnostic reasoning panoramic radiographs confirm all permanent teeth are present, and that the roots of the upper lateral incisors are intact, no resorption. A lateral cephalometric radiograph gives us numbers that tell a story. SNA equals 81 degrees. SNB equals 79.5. So the A and B difference is 1.5, slightly class 3. The mandibular plane angle sits at 28 degrees, indicating mild vertical growth with balanced facial proportions. These readings show that a girl's class 3 tendency is mild, mostly dento-alveolar, not skeletal. That distinction opens several treatment paths, each with its own advantages and risks. Treatment. Aims. The aims are clear: relieve crowding, align the canines, correct the anterior crossbite, and re-establish a positive overjet and overbite. We also want to correct the upper midline shift and create a stable class 1 molar relationship bilaterally. Treatment options explained. There are two main routes for achieving these aims. Option 1. Extractions. Removing a premolar on each side creates space for alignment and allows the upper arch to be positioned inside the lower, a classic approach for mild class 3 camouflage. Option 2. Arch expansion. Expanding the upper arch, both laterally and anteroposteriorly, can correct crossbites and provide room for the canines to erupt. It also postpones extraction decisions while monitoring mandibular growth. This second approach is often called therapeutic diagnosis. You treat conservatively first and reassess once growth completes. Choosing the path the girl's mother was anxious about extractions. After discussion, the team decided to attempt expansion first, knowing that further adjustments could follow later if necessary. The selected appliance, a quad helix expander. The quad helix appliance explained. Simply think of the quad helix as a spring-shaped scaffold across the palate. It's made of stainless steel wire, anchored to the upper first molars with cemented bands. When activated, its helices apply gentle, continuous pressure, widening the arch by roughly half a tooth's width on each side per adjustment. This expansion not only makes room for the canines, but also corrects posterior crossbite tendencies. The key advantage: it acts slowly and physiologically, respecting the sutural adaptation of growing patients. Early progress. After several months, the upper arch widened sufficiently. The canines began erupting more favorably. At this stage, light nickel titanium arch wires were introduced to begin alignment. Why 90? Because these wires are highly flexible and deliver gentle, consistent forces. They recover their shape even after deflection, perfect for early stages where teeth are far from the arch form. Re-evaluating progress interim records were taken, intraoral photos, new study models, and another cephalometric radiograph. By comparing these to initial measurements, clinicians could evaluate skeletal changes and dental-alveolar compensation. If the mandibular base hadn't grown excessively forward, continuing orthodontic camouflage would remain safe. If growth had shifted unfavorably, future orthodontic consultation might be considered after adolescence. In a girl's case, growth remained stable. The team proceeded with fixed appliances on both arches, non-extraction. Biomechanical reasoning in a girl's case. Why does expansion work in mild Class 3 cases? Because by broadening the upper arch, we increase the perimeter enough to relieve crowding and allow canines to erupt into alignment. Additionally, the forward tipping of upper incisors improves overjet, partially camouflaging the mild skeletal discrepancy. However, excessive expansion risks buccal tipping of molars, reducing occlusal contact and stability. So, clinicians must measure progress carefully, visit by visit. Finishing and retention. Once alignment and intercuspation were achieved, retention followed the same principles used for a girl. Bonded lower canine to canine retainer for anterior stability and upper and lower vacuum form retainers for nighttime wear. Retention continues for at least 2 years, longer if growth is still active. In a girl's case, follow-up at 12 months showed excellent stability, positive overjet, and corrected centerlines. Key lessons from Case 3. A girl's treatment highlights 3 teaching pearls. First, buccal eruption is not just about space. It's about timing and balance between skeletal growth and tooth eruption. Second, therapeutic diagnosis allows safe experimentation when growth direction is uncertain. We treat while observing. Third, retention remains the silent pillar of long-term success, expanding the clinical understanding, crowding and growth. Crowding is dynamic. In childhood, arches expand naturally as the face grows. But if eruption timing or primary tooth loss disrupts this process, permanent teeth lose their intended guidance. In mixed dentition, this often leads to temporary irregularity. But when discrepancy exceeds 5 mm, spontaneous correction is unlikely. Intervention becomes necessary. Upper canines, being late erupters, are the most vulnerable. They act like guests arriving last to a full dinner table. If no seat remains, they stand outside, buccally displaced. Clinical analogy. Tooth traffic. Imagine traffic merging onto a highway. Incisors are the early cars. They enter first and occupy their lanes. The canines come later. Heavy, directional, and essential for guidance. If no lane opens up, they swerve to the shoulder, the buccal corridor. Your job as an orthodontist is the traffic controller, deciding which cars to reroute, which to slow down, and where to expand the road. Anchorage control. The hidden power. Anchorage is what separates good treatment from relapse. It's the resistance to unwanted movement while targeted teeth are repositioned. In upper arch crowding with buccal canines, anchorage is critical because every forward drift of molars steals the space the canines need. You can reinforce anchorage with palatal arches, transpalatal bars, Nance appliances, or TADs, temporary anchorage devices. The choice depends on patient cooperation, skeletal maturity, and treatment complexity. Risks and patient education. Every fixed appliance treatment carries predictable risks. Patients should be informed clearly. The main ones include enamel demineralization and white spots, root resorption, loss of tooth vitality, and relapse if retention fails. When patients understand these early, they're more motivated to maintain hygiene and follow retainer protocols. Oral hygiene and lifestyle advice. Tell every patient this simple rule: if you can't brush, don't eat. Brushing after each meal, using fluoride toothpaste and interdental brushes, reduces almost all appliance-related problems. Carbonated and sugary drinks must be minimized. Even healthy, juices are acidic enough to damage enamel near brackets. During appointments, reinforce hygiene visually. Show plaque with disclosing tablets. Nothing teaches like seeing it glow pink around brackets. Retention. The final chapter of every case. Retention begins the moment active movement stops. Without it, teeth will drift toward their original positions. Fixed retainers on lower anteriors and removable retainers for both arches should be monitored regularly. Patients often underestimate this phase. But retention isn't just maintenance, it's the bridge between treatment success and long-term stability. Long-term prognosis. The long-term stability of corrected buccal canines depends on several factors: achieved overbite, posterior intradigitation, controlled mandibular growth, and continuous retainer use. When these align, relapse is rare. But if mandibular growth continues beyond the average, especially in late adolescent boys, minor relapse may appear. Periodic review every 6 to 12 months keeps these under control. When you think about it, buccal canines are more than displaced teeth. They're storytellers of developmental imbalance. They reveal how a few millimeters of space, a few months of growth, or one retained primary tooth can shape the entire face. Orthodontics is the art of predicting those small imbalances and guiding growth back toward harmony. From Case 1, we learned about classic crowding and extraction logic. From Case 2, we saw how biology, not mechanics, can define the treatment path. And from Case 3, we explored growth, expansion, and the value of patience. Together, these stories remind us: every smile carries a map of growth, biology, and human uniqueness. Thank you for watching this masterclass on crowding and buccal upper canines. If you found it valuable, share it with colleagues and dental students. Knowledge grows when it's passed forward. Stay curious, stay observant, and always respect the biology behind the mechanics.